Introduce our speaker for today.
Thank you, Danielle. So it is my great pleasure to introduce today's Grand Round speakers, Dr. Lorinda Chung and Srijana Devaluri. Dr. Chung is a professor of medicine and rheumatology at Stanford, specializing in scleroderma care and research. She is the section chief of rheumatology for the Palo Alto VA healthcare systems. She also heads the Stanford Scleroderma Center of Excellence, as well as directs several clinical trials to further care of patients with scleroderma. And as if not enough, Dr. Chung is also an amazing triathlon athlete, having competed in several competitions. Dr. Chung is also an outstanding teacher and mentor, being highly involved in the fellowship program and has received multiple awards for her teaching excellence. And as a beautiful testimony to that, we will also hear today from one of her current rheumatology fellows, Dr. Devaluri, sharing on her study on genetic contributors to calcinosis in scleroderma and dermatomyositis. So with that said, thank you both for joining us today, and we are much looking forward to your presentation.
Thank you so much, Christian, for the very nice introduction and also for inviting me to speak here today at your Grand Rounds. I'm going to try to share my screen now. Can everybody see that?
Perfect.
Okay, great. So today I'm going to speak about one of my areas of research interest, calcinosis in systemic sclerosis. This is a very challenging clinical problem. I think you'll all agree with me on that. And I'll just be presenting some results from our research studies, focusing on investigating the etiology, developing outcome measures, and I'll briefly talk about some clinical trials at the end. Here are my disclosures. And I first wanted to start with a case that illustrates some of the clinical features that are associated with calcinosis in systemic sclerosis. So this is a case of a 38-year-old female, one of our patients, who presents with Raynaud's phenomenon, joint pain, progressive diffuse skin tightening, and digital ulcers affecting her dorsal hand joints and her elbows. She develops progressive interstitial lung disease, proximal muscle weakness, and is found to have the PMSCL antibody. 10 years after she presents, she develops progressive calcinosis in areas of prior ulceration. She also has a new diagnosis of osteoporosis at a fairly young age, in her late 40s, despite not taking significant amounts of prednisone. So just showing some x-rays of her hands, you can see her significant contractures, and there are areas of calcinosis affecting her thumb, her PIPs over the second and fourth joints, and DIP joints of her fifth digit. All of these areas had prior ulcerations. Again, here's a healed ulcer over her elbow with underlying calcinosis, and you can see some calcinosis involving her forearm as well. And this just shows the corollary x-rays with calcinotic lesion affecting the elbow and some lesions affecting the forearm more distally. So just a little background on calcinosis and connective tissue diseases. I think you all know this, but they are calcium deposits under the skin that can form either as subcutaneous nodules of various sizes and shapes, or sometimes can be plate or plaque-like, especially in dermatomyositis. In systemic sclerosis, the most common locations are typically the hands, followed by the elbows and knees, and then truncal and face areas are less frequently involved. In dermatomyositis and juvenile dermatomyositis, the extremities and trunk are more frequently involved than in systemic sclerosis. The calcium deposits are made of calcium hydroxyapatite crystals, which are comprised of calcium, hydroxides, and phosphates. So there are several complications of calcinosis clinically. Predominantly, patients suffer from pain, and this can be related to calcinosis over pressure areas or related to inflammation caused or surrounding the areas of calcinosis. This leads to impaired function, particularly when involving the hands. Ulceration can occur, and infection also can affect these lesions. Rarely, in larger lesions, there can be a mass or pressure effect on nerves and other structures that can affect function. So calcinosis is classified as dystrophic, metastatic, or idiopathic. And calcinosis in connective tissue diseases is considered a dystrophic form, where damaged tissues result in calcinosis development, and these patients have normal serum calcium and phosphorus levels. This differentiates from patients with metastatic calcinosis, where there are normal tissues but high serum calcium and phosphorus levels. And this occurs in patients with chronic renal failure, hyperparathyroidism, sarcoidosis, and other entities like malignancies and high vitamin D levels. Idiopathic calcinosis is less common and is more associated with familial causes of calcinosis, such as tumoral calcinosis, where there can be high phosphorus levels and normal calcium levels with very large areas of tumoral calcinosis. So there have been a few different phenotypes described for calcinosis, and patients with systemic sclerosis typically have the circumscripta form, the first form shown here, which is usually clinically apparent as superficial nodules or plaques, often affecting the fingertips. Less commonly, patients with systemic sclerosis can have tumoral lesions, which are larger nodules that can extend into the muscle. This is much more common in patients with dermatomyositis or JDM, where up to 20% of patients can have tumoral calcinosis. Calcinosis affecting fascial planes along tendons or muscles, as shown here, is much less common in systemic sclerosis, but can be seen in about 15% of JDM patients. And then exoskeleton is incredibly rare in systemic sclerosis and seen in about 10% of JDM patients. So first, I wanted to talk about some of our research studies that elucidate some of the etiology and pathophysiology behind calcinosis. 5 different factors have been evaluated, not just by our group, but by other groups, including abnormalities in bone matrix proteins, vascular hypoxia, recurrent trauma, genetic factors, and chronic inflammation. So we're going to focus on the first 4 etiologies. And the first 3 highlighted in red, I'll give you some data from our observational studies that support these etiologies in calcinosis. Then I'll hand over the screen to Srijana, who will present some recent research we've been doing on genetic factors involved in calcinosis etiology. So the Scleroderma Clinical Trials Consortium developed a calcinosis working group back in 2012. And this is a multidisciplinary international collaborative group, all focused on research on calcinosis in systemic sclerosis. There are rheumatologists, radiologists, and dermatologists involved in this collaborative group and throughout the world, the UK, the EU, US, and Canada. The 4 major areas of interest for our working group have been first to develop a multi-center registry of calcinosis patients to evaluate clinical features and outcomes. Secondly, to develop calcinosis assessment tools. Third, to understand the pathophysiology underlying calcinosis and systemic sclerosis. And finally, ultimately, to develop potential treatments for calcinosis. So the first study I'm going to talk about is our retrospective cohort study, which included over 5,000 systemic sclerosis patients from 9 centers. And we basically evaluated for the frequency of calcinosis as defined by evidence on X-ray and or physical examination. 25% of this cohort had calcinosis. And in terms of clinical associations, there was no significant difference in calcinosis presence by cutaneous subset. However, it was associated with longer disease duration and various autoantibodies, including the anti-centromere antibody, the PMSCL antibody, and interestingly, the anti-cardiolipin antibody. The SCL70 antibody and RNA polymerase III antibodies were actually protective from the development of calcinosis in this study. So we performed logistic regression analyses in both univariate and multivariate analyses. And in the multivariate analysis, we found that female gender, telangiectasias, cardiac disease, gastrointestinal disease, and the anti-centromere antibody were all associated with the presence of calcinosis. But the two clinical features that were most highly associated were the presence of digital ulcers at any time in the disease history and the presence of osteoporosis. Both of them were highly associated with the presence of calcinosis with an odds ratio of about 4 or more. So we went on to develop a prospective multi-center study where patients were prospectively enrolled into this database in order to compare patients with and without calcinosis to validate our clinical correlations with calcinosis that were identified in our retrospective study. We also wanted to uncover novel information regarding calcinosis and systemic sclerosis, including specific locations and complication rates. So we developed a REDCap database, and this study was led by Antonia Valenzuela, who is an assistant professor at the University of Católico in Chile. And she developed this database, and 10 centers throughout the world were enrolling patients who fulfilled 2013 ACR-EULAR criteria for systemic sclerosis. And the patients were enrolled on a consecutive basis at baseline, then had a follow-up at 1 year. So we were able to enroll 568 patients in this prospective cohort. The mean age was about 58 plus or minus 10 years. Primarily, patients were female, 88%. 57% had limited cutaneous disease, and the majority of patients, 73%, were Caucasian. The disease duration from first non-Raynaud symptom was about 11 years, and from the first Raynaud symptom was about 15 years. Out of this 568 patients, 215 or 38% had calcinosis. So a bit higher than our retrospective study, which had about 25% of patients with calcinosis. Again, we looked at predictors of calcinosis in this cohort of patients. And in our multivariate analysis, digital ischemia, again, predicted the presence of calcinosis with an odds ratio of 1.8 in multivariate analyses. However, the presence of osteopenia or osteoporosis did not have a significant association with calcinosis in this prospective study. So we feel that it was unclear whether or not osteoporosis has a true association with calcinosis, but the thought is that there still is some involvement of dysregulation of bone matrix proteins in the development of calcinosis. And clearly, digital ischemia or digital ulcers are highly associated with calcinosis and supporting the role of hypoxia in its development. We also, in the prospective study, looked at the locations of the calcinotic lesions in these patients, and there were almost 1,500 lesions in these 568 patients. As we expected, the majority of the lesions occurred on the hands or the fingers, 73%, with 6% affecting the elbows, 5% affecting the knees, and 5% affecting the arms and or forearms. Within the hands, the thumbs were the most affected with calcinotic lesions, followed by the index fingers and middle fingers, and then less likely in the ring or small fingers. So our study validated the findings that Erin Herrick had found in a prior study where the thumbs and index fingers had the highest number of lesions thought to be related to recurrent trauma, since those are the fingers of the hands that are most frequently used. We also looked at complication rates in this cohort, and complications occurred in 74 patients, or 34% of the patients. Most of these, 46 of these patients, experienced more than one of these complications. So the most frequent complication was tenderness around the calcinotic lesions, followed by breaking through the skin, and ulcerations over the calcinotic lesions an erythema occurred in 15 and 12 patients. And infection actually had a very low prevalence in our cohort, with only 4 patients being affected by infection. So now I'm going to move on from our cohort studies to a study that we performed at Stanford with Robert Fairchild, who is our musculoskeletal ultrasound expert at Stanford. So we did an ultrasound evaluation of calcinosis in scleroderma patients. 43 patients were enrolled, 19 with diffuse disease and 24 with limited disease. At the same time, we did bilateral x-rays of the hands and wrists, in concomitant, and as well performed bilateral ultrasounds of these areas with vascular measurements. So we looked at ulnar artery occlusion, finger pulp blood flow, and then developed a composite score of blood flow combining ulnar artery occlusion and finger pulp blood flow. So just to show you what this looks like, first of all, in panel A, this shows a radiograph of calcinosis, and the same patient's ultrasound is in panels B through D. So as you can see, there are multiple calcinotic lesions affecting the fingers in this patient, and this is the longitudinal aspect, a longitudinal palmar aspect of the second finger, and the arrowheads indicate areas of calcinosis affecting that finger. C1 and C2 are looking at evidence of finger pulp blood flow. And in C1, this is absent blood flow, so you see no Doppler activity, whereas in C2, there is normal finger pulp blood flow. In D1, this is evidence of ulnar artery occlusion. Again, we see that there's no Doppler signal here, but in the area where there is no ulnar artery occlusion, you can see the Doppler signal. So fairly easy to visualize on the ultrasound. And then we determined whether or not there was an association between ultrasound markers of pathologic blood flow and calcinosis. And what we found was that the presence of ulnar artery occlusion had an 8-fold increased risk of calcinosis. And the association with calcinosis was even higher in those patients who never had a history of digital ulcers, with an odds ratio of 33. Of course, this had a very wide confidence interval because of our small sample size. Finger pulp blood flow and the composite score did not actually meet statistical significance with respect to its association with calcinosis. But ulnar artery occlusion, definitely a sign associated with calcinosis, and this could be a clinical assessment that you can do to look for patients who would be at risk for developing calcinosis in the future. Now I'm going to hand the screen over to Srijana to talk about the role of genetics in calcinosis.
Thank you, Lori. Okay. Okay. So as part of our ongoing research efforts, we wanted to explore the role of genetics in the development of calcinosis associated with scleroderma and dermatomyositis. So we have extrapolated the research findings from other ectopic mineralization disorders which have a genetic basis, like pseudoxanthoma elasticum and generalized arterial calcification of infancy. These diseases are both heritable and characterized by calcifications in skin, eyes, as well as blood vessels. They have a wide phenotypic heterogeneity that has been explained by the presence of variants in ABCC6 and ENPP1 genes, which contribute to the regulation of mineralization. So our hypothesis was that we have rare genetic variants that drive the severe calcinosis phenotype in these diseases. And to define severe calcinosis, we have divided the human body into roughly 17 anatomical areas based on the modified Rodnan skin score outline as shown in this slide here. And we have defined severe calcinosis as presence of at least 3 areas of calcinosis or more than 3 centimeters of a single calcinotic lesion at any time during the follow-up of a patient. For example, patient 1 had calcinosis in the right shoulder blade, the right thigh, and the left thigh, which contributes to 3 areas of calcinosis. And patient 2 had calcinosis in both the hands as well as the foot and the pelvis area, which contributes to 4 areas, and hence both the patients meet the eligibility criteria for the study. So we have identified 31 scleroderma patients and 19 dermatomyositis patients who were at least 18 years of age at the time of cohort entry and the blood collection, on whom whole genome sequencing has been performed. This is the baseline demographics of the patients. The mean age of the patients in scleroderma cohort was 58 years, whereas in dermatomyositis cohort, the mean age was 44 years. Majority were female biological sex. And we had a diverse group of patients who are coming from different racial and ethnic backgrounds, as shown in the slide here. And nearly 50% of patients in scleroderma cohorts had anti-centromere antibody, and the mean disease duration was 15 years. And 3/4 of the patients had digital ulcers, which again emphasizes the association of vascular dysfunction and hypoxia in patients with calcinosis. And in dermatomyositis cohort, MDA5 antibody was closely followed by NXP2 antibody in the patients who had severe calcinosis, with a mean disease duration of 7 years. Although we started with the involvement of at least 3 areas with calcinosis, the mean number of areas with calcinosis was 5 in these patients, and nearly 50% of patients had undergone surgical debridement for their calcinosis management. Now, from the genome sequencing results, we have analyzed the results in 2 ways. First, we have applied a filter of minor allele frequency of less than 1 in 100 to make sure we are looking at only the rare variants. And we have identified 39 singleton gene variants in 24 genes that have been previously reported in other calcification disorders. And among the 39 gene variants, 6 belong to ABCC6 and 2 belonged to ENPP1 genes. And the second filter that we have applied was increasing the threshold of minor allele frequency to less than 1 in 10,000. And we still have the ENPP1 gene that shows up as a significant result. Now, why are we excited about these results is explained in this slide. So ABCC6 gene is a gene that encodes a transmembrane protein that transports ATP from hepatocytes into the bloodstream. And ENPP1 encodes ectonucleotidase enzyme that breaks the ATP to inorganic pyrophosphate. The inorganic pyrophosphate circulating in bloodstream inhibits calcification in tissues. When you have variants in these genes, you can have decreased inorganic pyrophosphate and with resulting increased tissue calcifications. Hence, we conclude that ABCC6 and ENPP1 gene variants, which are known to be involved in dystrophic calcification in other diseases, are present in the severe calcinosis phenotype of patients with scleroderma and dermatomyositis. We are currently analyzing the HLA alleles and the diversity in the subgroups to identify potential mechanistic pathways, and we aim to measure and compare the levels of serum inorganic pyrophosphate between patients with these variants and without the variants. And other functional studies on rare coding variants that have been identified in the whole genome analysis are also currently being planned, and maybe explore the potential role of inorganic pyrophosphate supplementation in the treatment of calcinosis in patients carrying these variants. I would like to thank our colleagues from University of Washington, Dr. Christian Lode, who has participated in this project and gave us this opportunity to present our results in this grant rounds. And I would like to thank our colleagues from NIH and Johns Hopkins Medicine who have helped us with the genetic analysis and made this project a success. And Dr. Lorinda Chung and David Fiorentino, who gave me the opportunity to be a part of the research group and the T32 grant that supported my research fellowship duration. I'll hand over to Lori. Okay.
Okay, thank you so much, Srijana. Now I'm going to switch gears a little bit and talk about a few studies that we've done looking at outcome measures for scleroderma-associated calcinosis. The first studies look at the development of an X-ray severity scoring system, where we have validated this according to reliability as well as change over time. We are also in the process of developing an ultrasound severity scoring system. And then finally, I'll touch a little bit on the Maudsley patient-reported questionnaire, which has been developed by Leslie Seketku with our group. So first, to talk about the X-ray severity scoring system for calcinosis of the hands in patients with systemic sclerosis. So we divided the hands into 22 anatomic regions. And this scoring system takes into account the percent area coverage on a scale of 0 to 100, density on a scale of 1 to 3, and the anatomic location. So the 22 different anatomic locations are weighted, and all of the scores from those locations are summed together to give a final score for each X-ray. So this first study looked at the reliability of our complex scoring system. There was a prior study performed by Aaron Herrick's group, which used a simple scoring system that categorized calcinosis burden as mild, as shown in this X-ray here, with just one lesion of low density, moderate, which has at least a couple of lesions of moderate to higher density, and then severe, where there are multiple lesions of high density. And the simple scoring system is scored on a scale of 0 to 3. 0 is no calcinosis, 1 is consistent with mild, 2 moderate, and 3 severe. As I described in the prior slide, our complex scoring system uses these 22 anatomic regions. And essentially, we ask the investigators to estimate the percentage area covered with calcium in each of these 22 different areas to the nearest 1%. So when we looked at the reliability of these two different scoring systems, the simple scoring system had a poor overall inter-rater reliability with a kappa statistic of 0.39. When we dichotomized the simple scoring system, combining mild and moderate scores compared to severe, this improved the kappa statistic to 0.51. But compared to the complex scoring system, the inter-rater reliability was very high with an intra-class correlation coefficient of 0.89. The intra-rater reliability was also lower in the simple scoring system at 0.67 compared to almost perfect correlation with intra-rater reliability for the complex scoring system with an ICC of 0.93. So subsequent to that study, we wanted to look at the ability of the complex scoring system to change over time. So we enrolled 39 systemic sclerosis patients with calcinosis from 6 different centers from the SCTC prospective cohort. And we also had another cohort of patients with calcinosis from Leeds, including 9 scleroderma patients, to use as a validation cohort. All of these patients had baseline and 1-year hand X-rays of both hands. And 2 readers scored all of the X-rays with the complex scoring system, as well as using a Likert for follow-up evaluation. The Likert scale was measured on a scale of 1 to 5, 1 as a lot better, 2 a little better, 3 no change, 4 a lot worse, and 4 a little worse, and 5 a lot worse. So we determined change over the 1-year period of time by maximizing the kappa coefficient between the reader's radiologic and Likert scale scores. And this led to the definition of progression as greater than a 25% increase in score from baseline at 1 year, stability as anywhere between minus 25 to plus 25% change in score from baseline at 1 year, and improvement as a greater than 25% decrease in score from baseline at 1 year. So these 2 graphs show the distribution of change in calcinosis score over a year in A in the original cohort and in B in the validation cohort. And what you can see is that the largest percentage of patients actually remain stable over the 1-year period of time, 46% in the original cohort and 53% in the validation cohort. There was a very large percentage of patients who did have progression over the 1-year period of time, 41% in the original cohort and 37% in the validation cohort. Interestingly, there was, however, a small group of patients who did have improvement over time, so 13% and 11%. When we looked at predictors for progression and improvement of calcinosis over a 1-year period of time, we were able to perform univariate analyses for predictors of improvement and found that positive PMSCL had a statistically significant association with improvement of calcinosis over 1 year with an odds ratio of 17. However, again, large confidence interval due to the small number of cases. And because of the small number of improvers, we were not able to perform multivariate analyses. For predictors of progression, there were obviously more patients, and we were able to perform multivariate analyses. And we found that the loss of digital pulp was a predictor of progression of calcinosis, both in univariate as well as multivariate analyses. So again, this shows some support for the role of digital ischemia in the development of calcinosis and progression. Now I'm going to move from the X-ray studies to a study that's currently ongoing called the STONE study. This is an ultrasound-based outcome measure of soft tissue calcinosis in scleroderma development project. And this is being supported by the Scleroderma Clinical Trials Consortium Working Group grant. Lorraine Green from University of Leeds and Robert Fairchild from Stanford are leading this project. So just to give you some background, Dr. Green had performed a Delphi exercise with 2 rounds of Delphi assessment with 32 experts in ultrasound. And through this work, they were able to come up with a consensus definition of calcinosis, where there was agreement in the definition of presence of calcinosis in 89% of the experts, agreement in an operational description of calcinosis in 82%. And then subsequent refinement of the definition has been performed to be assessed in round 3 of a Delphi exercise. There were also ultrasound features that were identified to be important in calcinosis assessment and reporting, including inflammation, skin features, tendinopathy, bone and joint pathology, and blood flow features. So the first aim of the STONE study is to validate an ultrasound definition of calcinosis and identify ultrasound features associated with calcinosis severity. We have already enrolled 70 patients with systemic sclerosis with a total of 70 calcinosis lesions affecting the hands. And these lesions are of varying patient-reported calcinosis severity. We also enrolled 10 patients with no calcinosis to look at correlative regions of interest to compare to those with calcinosis. All the patients have undergone ultrasound with B-mode and power Doppler per lesion and region of interest in the controls. And they've also had X-rays to compare validated severity scores of the hands and the regions of interest. Patient demographics, clinical characteristics of the lesions, and patient-reported outcomes were collected from all of these patients. So we haven't performed all of the analyses yet to describe the cohort, but that's ongoing. And the second study aim, which will follow, is to develop the ultrasound severity scoring system and to assess its feasibility, reliability, and correlation with patient-reported outcome severity. So we're at the data analyzing stage, and the ultrasound images are being scored and analyzed for inter-rater and intra-rater reliability, as well as correlation with patient-reported outcome measures. And regression analysis is going to be performed to derive a weighted ultrasound severity scoring system. In addition, it will be combined with the X-ray severity scoring system to develop a composite score for further validation. Feasibility of the ultrasound scoring system is going to be measured by combining the median image acquisition and rating times. Finally, the third aim, which will be taking place after study aim 2 is completed, is to validate the ultrasound calcinosis severity scoring system in a prospective ultrasound workshop of scleroderma patients with calcinosis. So the last outcome measure that I wanted to talk about is the Maudsley Calcinosis Patient Questionnaire. And this was really spearheaded by Leslie Sakeku, and a group of us all worked together to analyze some of the data that we've collected on this calcinosis questionnaire. So there were 6 international patient focus groups that were held, as well as semi-structured interviews of 31 scleroderma patients with calcinosis in order to determine what areas were important to patients with calcinosis. The study team included 4 scleroderma experts, 3 patient research partners in scleroderma, a researcher trained in psychometrics, and 4 experienced patient-reported outcome measure developers. Field testing was performed of 21 potential items evaluated with face-to-face interviews of 9 scleroderma patients with calcinosis who were separate from those from their original interviews. The validation is still going on, and we're now using the SCTC scleroderma prospective cohort, where we did collect the Maudsley questionnaires at baseline in 1 year to further validate this questionnaire. So just to show some of the questions that are asked in this questionnaire, how many calcinosis lesions do you actually have today? How many lesions do you feel you have today? How many digital ulcers do you have? And how many of these digital ulcers do you think are related to calcinosis? Then there are multiple visual analog scale questions, including an assessment of Raynaud's and digital ulcers, assessment of pain, tightness or pressure over the calcinosis lesions, whether you think the calcinosis is growing, it's throbbing, is it tender to touch, have you felt you needed to protect the areas of calcinosis? And then there are other more psychometric parameters that we've incorporated into the questionnaire, looking at how fearful you are or worried about your calcinosis, worried that it won't heal. How does it interfere with self-care and the use of your hands? How does it interfere with walking? And then how it interferes with the ability to work, your mood, and how you interact with friends and perform other recreational activities. So this questionnaire is the only calcinosis questionnaire that is currently being evaluated, and it's also being evaluated in patients with dermatomyositis, though it wasn't developed in that patient population. So the last study that I'm going to talk about is a clinical trial that we performed at Stanford, which was a pilot study to evaluate the safety and efficacy of treprostinil in the treatment of calcinosis in systemic sclerosis. And I wanted to highlight the 2 lead authors, Melody Chung and Antonia Valenzuela, both of whom were prior fellows of mine, prior research fellows. So our hypotheses were that calcinosis is in part a result of microvascular injury and ischemic damage, and a powerful vasodilator such as treprostinil may decrease the progression of calcinosis in systemic sclerosis. So oral treprostinil has been approved for the treatment of pulmonary arterial hypertension for years. And a study was performed back in 2015, 2016, looking at oral treprostinil for the treatment of digital ulcers in patients with systemic sclerosis. This was a multi-center, double-blind, placebo-controlled clinical trial. And unfortunately, the primary endpoint of reducing net ulcer burden at week 20 was not met. There was no significant difference between the treatment and placebo groups in terms of change in net ulcer burden at week 20. However, if you look at week 15, there actually was a statistically significant difference between the groups. So the mean change from baseline in the net ulcer burden was negative 0.37 compared to a positive 0.07 in the placebo group. So with this background, and also the fact that the study that was performed for the digital ulcers actually used a BID dosing regimen, it was subsequently found that the medication's serum levels were much more consistent if taken TID. So we developed this study to assess the safety and tolerability of oral treprostinil using a TID dosing regimen in scleroderma patients with calcinosis affecting the hands. Our goal was also to complete the first prospective clinical trial for scleroderma-associated calcinosis using the SCTC radiographic scoring system. And finally, to assess the efficacy of oral treprostinil in preventing progression of calcinosis over 1 year based on the radiographic scoring system. So this was an open label proof of concept pilot study, and 12 patients with scleroderma were to be enrolled with at least one calcinosis lesion of the hands that is palpable on physical exam and also measurable on hand radiographs. Patients were treated with 1 year of oral treprostinil at a TID dosing that was titrated to maximum tolerated dose, as other prostacyclin studies have done. There was one blinded radiologist from Stanford, Kate Stevens, who assessed and scored baseline and 1 year hand radiographs. And the definition of progression, stable disease, and improvement was as defined in our SCTC prospective X-ray study. So the 25% change really differentiated progression, stable disease, and improvement. We did enroll 12 patients, median age 55 years, with 100% of patients female and 75% Caucasian. 50% of them had diffuse cutaneous disease, and they were all long-standing disease. Years from first Raynaud's symptom was 15 years, and from first non-Raynaud's symptom was 12 years. A third of patients had smoked in the past. 50% had a positive anti-centromere antibody, and 17% had a positive antiphospholipid antibody. 75% of these patients had prior digital ulcers, and one patient had gangrene in the past. The majority of patients were on some sort of baseline vasodilator therapy or treatment for their Raynaud's, 42% on a calcium channel blocker, 17% on an SSRI. And about 50% of patients were also on immunosuppressive therapies for other comorbid conditions like interstitial lung disease. A third of the patients were on Cellcept, and 17% were on methotrexate. Unfortunately, only 5 of the 12 patients completed the whole 1 year of treatment. 7 patients discontinued sometime along the trial, 3 due to intolerable side effects, which were most commonly what you would expect from prostacyclins: headache, abdominal pain, diarrhea, nausea. And 2 patients had unrelated illness, cirrhosis, and cancer, so they had to discontinue. 1 had scleroderma progression, and 1 discontinued for personal reasons. 11 of the 12 patients, despite the fact that 7 patients discontinued the treatment, completed their baseline and 1-year follow-up hand x-rays. Of those 12 patients, or of the 11 patients, 4 of them, or 36%, had progression of calcinosis on x-ray. And that was a little bit less or similar to what we found in the prospective cohort of patients at 1 year. However, 3/4 of those patients dropped out of the study early, so did not receive the full 12 months of treatment with treprostinil. Of the 5 patients who did complete the 12 months of treprostinil, 4 of them, or 80%, had stable X-ray scores. And this is my last slide that I just wanted to put up to show you that we do have some therapies that show some potential for future evaluation in clinical trials. So certainly there are other vasodilatory agents that could be evaluated: phosphodiesterase inhibitors, endothelin receptor antagonists, guanylate cyclase stimulators, and other forms of prostacyclins. Regulators of bone metabolism, some of which have been used to treat calcinosis in the past, like bisphosphonates. These may show some benefit in the prevention of progression of calcinosis. Anti-inflammatories like IL-1 inhibitors, TNF inhibitors, and rituximab have shown some efficacy in treatment of calcinosis in case reports, but really needs to be evaluated in clinical trials, and in particular might be more effective in those patients with inflammatory lesions, both clinically as well as in terms of having elevated ESR, CRP, or IL-6 levels. And then finally, we are using calcification inhibitors for the treatment of calcinosis in many of our patients. There's more data and more evaluation looking at sodium thiosulfate, which is used clinically for the treatment of calciphylaxis in IV and injectable forms. So there's probably going to be more data on sodium thiosulfate efficacy in the upcoming months. And then finally, as Srijana outlined, there may be a role for inorganic pyrophosphate in the treatment of systemic sclerosis and DM-associated calcinosis. So in summary, calcinosis is a complication of systemic sclerosis that's associated with longer disease duration, digital ulcers, and particular autoantibody profiles, such as the PMSCL and anti-centromere antibodies. Pathophysiologic mechanisms involved in the development of calcinosis, we believe, include vascular hypoxia, dysregulation of bone matrix proteins, recurrent trauma, and inflammation. Gene variants known to be involved in inherited calcification disorders are present in the severe calcinosis phenotype of systemic sclerosis and dermatomyositis, and may inform pathogenic mechanisms and potential targets for treatment. Novel imaging outcome measures and patient-reported outcomes are currently being developed and validated for use in clinical trials. And agents targeting vascular hypoxia, regulation of bone metabolism, inflammation, and calcification pathways need to be tested in prospective clinical trials. So I wanted to thank, I have a long list of people I would like to thank who really contributed to all the studies that I presented here. Antonia Valenzuela, my partner at Stanford in the Rheum Derm Clinic, David Fiorentino. Kate Stevens is our radiologist at Stanford. Joy Wu is our endocrinologist who helped analyze some of the osteoporosis data. Shufeng Ling is our statistician. And of course, Srijana, Pravit, and Christian, all instrumental in the genetic studies that were currently ongoing regarding calcinosis in scleroderma and DM. Robert Fairchild and Lorraine Green for the ultrasound studies, Leslie for the Maudsley questionnaire, Melody Chung and Vibeke Strand, who really helped with the treprostinil clinical trial. And of course, I'd like to thank the Scleroderma Research Foundation and the Scleroderma Clinical Trials Consortium, who have supported our work over these years. And this is just a group of us at the Stanford Scleroderma Center of Excellence. All of these are fantastic collaborators interested in scleroderma research. So I think we have some time for questions. I believe people have put questions in the Q&A. So why did you mention that 17% of the patients in the treprostinil study are on SSRIs? Does SSRI affect DU or calcinosis? So that's a great question. So I was mentioning the medications that the patients were on to treat their Raynaud's. And we frequently use SSRIs. In particular, we like Lexapro. It's just a well-tolerated SSRI. And we use it all the time in the treatment of patients with scleroderma-associated Raynaud's. So there was one clinical trial comparing, it was actually Prozac to nifedipine years ago, showing that there was at least equal efficacy of the SSRI compared to the calcium channel blocker, and even more efficacy in those with primary Raynaud's than secondary. But we find that this is a useful medication in patients with scleroderma-associated Raynaud's if they have low blood pressure or if they aren't able to tolerate calcium channel blockers for one reason or another, like edema. And finally, it's also very effective in those who have stress-induced attacks. So I would say up to 25%, at least 20% of our patients are on SSRIs for the treatment of Raynaud's. I have another question here from Dr. Wenner. Thank you for taking on this challenging issue and for such a comprehensive presentation. How well does Doppler ultrasound inflammation correlate with clinical symptoms and signs? So I would say we don't send a lot of our patients to the ultrasound clinic for evaluation of calcinosis unless they're undergoing treatment with injectable sodium thiosulfate, which Dr. Fairchild now does for several of our patients. And to be honest, I don't often send those patients who have a lot of inflammation. I'll try something else like minocycline, or maybe, we might even be starting to consider things like IL-1 blockers in those patients. But I would say that the Doppler signal association with clinical inflammation, such as erythema around the skin, is not always correlative. So there may be some more causes underlying the skin that is associated with calcinosis in the lesions themselves. Have you used or colchicine in patients with inflammatory findings? And have you considered additional trials of colchicine in these patients? So that's a great question. I have not found a whole lot of benefit from colchicine for the treatment of calcinosis. And I know that there have definitely been studies, both positive and negative, that have been published. And, the thought that colchicine does counteract the neutrophils, that this could be a well-tolerated medication that you might want to try. I have found much more clinical benefit from minocycline, and patients tolerate the medicine quite well. Chris Denton's group from the UK has done a retrospective study showing that minocycline use was associated with clinical improvement in calcinosis, but it was a retrospective, not a prospective study, and really didn't have any outcome measures that were validated used in that study. But I clinically think that minocycline has some benefit for those patients. And thank you, Lori and Srijana, for an important talk and for developing endpoints we can use someday for trials. How are you thinking about scoring systems for patients who do not have scleroderma and DM, and for those with calcinosis outside of the hands? Great question. So I think that there needs to be a lot more work for assessing calcinosis in dermatomyositis, because as you say, it does not frequently involve the hands. So although we're using the Maudsley questionnaire for the DM population as well as the scleroderma population, I think in terms of radiologic and ultrasound imaging, there needs to be a totally different assessment measure for patients with dermatomyositis because the extremities and trunk are so much more frequently involved. Adam Schiffenbauer is doing a lot of work in this area and looking at whole body CTs to come up with calcinosis burden using a similar calcification scoring system as that for coronary artery disease. So he had a recent publication, I think, within the past year that you should look at. And I think he's going to come out with much more interesting work in the near future. We have a few more minutes. Are there any other questions? Am I missing one? Okay. Dr. Wenner, it appeared that the image you showed of hand X-ray had vascular calciphylaxis. Do you think that plays a role frequently? Is there a role for statins? So I think that definitely calciphylaxis and, or shall I say, metastatic calcinosis definitely can affect patients with scleroderma. I think a different clinical phenotype than the case that I presented. And maybe in those patients who have end-stage renal failure related to prior scleroderma renal crisis, who then develop two different reasons to develop calcinosis and also may have calciphylaxis. On skin biopsy, you can clearly differentiate the difference between calciphylaxis and calcinosis cutis, or the pathologist can, but I think that this can occur in the same patient when they do have end-stage renal disease. Is there a role for statins? So there were some studies supporting the use of statins in the treatment of Raynaud's phenomenon, and certainly with the statins' effect on endothelial cells, it's thought that they can be helpful for improving blood flow and have also been evaluated for the treatment of digital ulcers. We have not at all looked at them for the treatment of calcinosis. That would be interesting. I think it might be difficult to do in patients with dermatomyositis or even scleroderma-associated myositis, but certainly interesting to look at the statin impacts on endothelial function and blood flow. Okay, Cherie, I'm a patient with calcinosis in my hand. Is surgical treatment successful? So I should have mentioned in my talk that we still feel that surgical removal is the most effective treatment for calcinosis if the lesion is accessible and amenable to surgical excision. The problem is when there are large conglomerated lesions that maybe aren't accessible, aren't right at the surface, those are difficult to surgically remove. And those are the ones that we're thinking about using injectable sodium thiosulfate, minocycline if there's inflammation, or if there are patients, especially with scleroderma, who have multiple small lesions. We do try sodium thiosulfate topically, and it often will help bring the lesions to the surface and extrude on their own. So, but yes, surgical treatment certainly is our first line of treatment. Okay, Faith Rubenstein. I am a patient with calcinosis. Any hope for ESWT? Shockwave therapy? Is that what you're saying? So unfortunately, there is not enough evidence that shockwave therapy is helpful for calcinosis. It may be that there aren't large enough trials, but thus far, it's only been kind of case report, case series showing evidence of benefit. And there really isn't an agreed upon method that is successful. Better luck with sodium thiosulfate topically. Yes, so again, we only use sodium thiosulfate topically for those kind of small lesions of the fingers where they're kind of accessible and it's easy for the sodium thiosulfate to absorb into the skin. Sometimes you can have patients, wear gloves or wrap the lesions in like saran wrap to help the sodium thiosulfate to absorb into the skin better. But really just for those small lesions. Okay, well, I think we're at the hour. Thank you all so much for your engagement and your questions and your interest in our talk today. And thank you so much, Srijana, for your hard work and for joining us today to present your really exciting work on the genetic factors in calcinosis.
Yeah, thank you, Sridhar.